Thank you, Agnivesh. I would like to start off by thanking Dr. Siddharth Yadav, Dr. Sanjay Dhar, Dr. Agnivesh for inviting me to take this lecture and for Apollo Hospitals to give me an opportunity to be here. The topic for today is thoracolumbar fractures, and it is, as Agnivesh said, for a general orthopedic surgeon, for a patient, for a person who is dealing with basic trauma and general orthopedics, it is a very vital topic. And even from the resident's point of view, it's a common topic which is asked in the exam. Thoracolumbar burst fractures have always been a controversial topic with varying opinions in literature, whether to operate or not to operate, how to classify a particular injury, what is stable, what is an unstable injury, whether you should approach this fracture from the anterior approach, posterior approach, combined approach, what sort of instrumentation to use. These are all controversial issues. There is a lot of debate on all these issues in literature. And in fact, if you look at Verlan's systematic review of literature, which covers 31 years of literature on thoracolumbar fractures, he concluded that evidence-based guidelines are lacking and that surgery is determined more by individual and institutional preference rather than any specific clear guidelines. Over the next 45 minutes to an hour, what I'm going to do is try to provide a stepwise algorithm for decision making in thoracolumbar fractures. The goal of this lecture is basically to make you understand the various basic concepts around thoracolumbar fractures and to help you to reach the decision making algorithm in a stepwise fashion so that 95% of the fractures can be treated by you safely without any complications and with the best of results. Sure, there are different ways of doing things, but if you follow this algorithm, you'll rarely go wrong. Why thoracolumbar fractures? Thoracolumbar region is the region between the thoracic spine and the lumbar spine and is said to consist of the D12, L1 and L2 vertebra. The thoracic spine is a kyphotic area. It is stabilized by wrists. It has small triangular vertebrae with short disc heights. The facet joints are oriented in the coronal plane, and the mobility in the thoracic spine is primarily rotational. On the other hand, lower down, the lumbar spine has much larger oval vertebrae with larger disc heights. The facet joints are oriented at 90 degrees to the coronal facet joints of the thoracic spine. And there is far more mobility in the lumbar spine with extension, rotations, lateral bending, flexion, etc. All this contributes to a huge mismatch between these two regions. And therefore, the intervening region, that is the thoracolumbar spine, is a transitional zone. It is neutrally aligned. There are floating ribs. There are facet joints which change orientation. And therefore, this area is extremely vulnerable to any injury. And 7% of all blunt trauma victims have a thoracolumbar spinal injury. In fact, if you look at the fracture distribution within the spine, almost 50 to 60% of spinal fractures occur within the thoracolumbar region. Whenever such a patient comes to you, you must be aware of the management outline. The first job is obviously at the site of injury, which is beyond your realm right now, and that is retrieval of the patient from the accident site and immobilizing the patient and doing the emergency resuscitation. Once the patient is brought to the emergency department of the hospital, the care consists of primarily three things: a hemodynamic stabilization, assessment of the patient, both clinical and radiological, and prevention of secondary spinal cord injury. Once the patient is stabilized, diagnosis is made. The time is to decide whether you can treat this patient. Does your center have the facilities to treat a patient of this type? Or would you rather transfer this to an institution which is of tertiary care and can handle it better? And the last part of the management is the decision making regarding what sort of treatment should be definitively offered, what should be the timing of treatment, and what is the precise technique. So let's discuss all of this. Here we start with the emergency care. The patient has come to the hospital, brought into the EMS. The first thing that all residents must know is that examination must be done on a spine board, where the patient is strapped down to the board. Because in an emergency, it is immobilization of the spine, which is a much bigger priority than to try to clear the spine of any injury. Every time the patient moves, there is a risk of developing or worsening neurologic deficit. And therefore, immobilization of a spine is extremely important. The airway, the breathing, and the circulation take precedence over anything else. In patients with spinal cord injury, it is vital to maintain an appropriate mean arterial pressure above 85 to 90 to maintain the spinal cord perfusion. It is also vital to maintain the the oxygen saturation in order to avoid hypoxia, which would increase the secondary spinal cord injury. Having done these two things, the next thing is to examine the patient from head to toe. Start by looking at the head and looking for any head injuries by examining the patient's orientation and looking at the GCS. Look at the chest, palpate for any rib fractures and auscultate for any problems. Palpate the abdomen, make sure it is soft. Look for injuries to the musculoskeletal system, especially the pelvis, any extremity fractures. And whenever you're looking at one spine fracture, remember that the incidence of non-contiguous spine fractures is as high as 50% on occasions. Having ruled out other injuries, the next job is to examine the patient's thoracolumbar spine. The clinical evaluation starts with understanding the mode of accident. In young patients, it is usually a high velocity injury occurring secondary to a motor vehicular accident or a fall from height. On older patients, on the other hand, develop thoracolumbar fractures more following a domestic fall. Patients usually on history will give you a history of pain in the back or history of weakness or numbness in the lower extremities and inability to move them. It is vital at this point to try and understand whether there were any similar spinal problems in the past. Spinal fractures are extremely common in patients with stiff spines, such as ankylosing spondylitis, patients with dish, or severe spondylosis. In these patients, if you do not take care to immobilize the patient in the position of their deformity, the spine ends up in extension, causing further neural damage. The examination of the spine, once you decide that now I want to examine the spine and look at the back, you must take the help of 6 people to log roll the patient onto the side for evaluation of the back. Examine the spine for tenderness, bruising, any hematoma or lacerations. Palpate for an interspinous steps or gaps between the spinous processes. Look for any spinal deformity such as a knuckle or a gibbous. At the end of this, you must remember that clinical examination in the absence of a neurologic deficit has limited sensitivity in terms of diagnosing a thoracolumbar fracture. The neurological examination is the next step in this emergency assessment. A detailed neurological examination must be performed once the patient is adequately stabilized and other injuries have been ruled out. And a precise record of this examination must be maintained. Neurological examination must be repeated frequently and recorded at each occasion. Examine the motor power, the sensory examination, look for the superficial and deep and pathological reflexes like the Babinski, or if the neck is injured, a Hoffman sign. Look for the bulbocavernosus reflex. I will talk a little bit more about that. And do not forget to look for perineal sensations and do a rectal examination. American Spinal Injury Association has come up with a standardized method of recording neurological deficits. So it would be ideal if you can record this so that you do not miss any aspect of the neurologic deficit. And this examination is repeated at frequent intervals. Having examined the patient, you can then classify the patient based upon the amount of neurologic deficit as complete, incomplete, or a patient with a normal motor and sensory neurology. It is vital to remember that neurological examination involves ascertaining whether the patient is in spinal shock or not. What exactly is spinal shock? Immediately after the injury, there is a physiologic disruption of spinal cord function. The spinal cord is unable to transmit impulses from the proximal part of the injury to distal to the injury. And therefore, distal to the level of the injury, you will find absence of the bulbocavernosus reflex. You may find flaccid paralysis in both the legs, hypotonia, absent reflexes. This stage of spinal shock may last from hours to days and sometimes weeks. During the phase of spinal shock, it is not appropriate to label the patient as a complete or incomplete neurologic deficit. Only after the bulbocavernosus reflex returns can you label this as the end of spinal shock, and then the injury can be graded as a complete injury in which there is no function below the level of injury, or an incomplete injury where there is preservation of some function below the level of injury. The next step, having done the clinical examination, is to do a radiological assessment. About 20% of all thoracolumbar fractures are missed on initial assessment, and therefore it is vital to be careful and try your maximum not to miss this. Whenever there is one fracture of the spine, always look for another injury in the spine. The incidence can be as high as 15% to sometimes even 50%. The radiological assessment helps to understand the morphology of the fracture, to diagnose any interruption or disruption of the disc or the ligaments, and to identify direction, etiology of spinal cord compression. The radiological assessment usually starts in our emergency rooms with plain X-rays. The plain X-rays are helpful because they are cheap, they are easily available, they can be done on all patients very expeditiously, and they have limited radiation. The problem with this is that the plain X-rays have a limited sensitivity, and in fact, the sensitivity is only 73% in terms of diagnosing a thoracolumbar fracture. On the AP view, one looks at the spinous processes and sees whether they are aligned centrally in the midline. One looks at both the pedicles and sees if there is any separation of the pedicles compared to the previous, to the level above or below, indicating that there might be a burst fracture. Look at the vertebral body height and see if there is any disruption of the bone, asymmetric collapse of the bone. Look at the transverse processes and the ribs adjacent to the vertebra to see if there are any fractures. And of course, in AP view, is there any translation in the coronal plane of the vertebra, indicating serious ligament instability. On the lateral views, one starts by looking from the front and looking for any malalignment of the vertebrae because of translation or rotation. Look for any collapse of the vertebral body with a loss of the anterior or posterior vertebral height, and fractures, if at all, of the posterior elements. However, as I said earlier, the X-rays have a limited sensitivity. And therefore, in a lot of institutions across the world, in patients with blunt trauma, where multiple injuries are suspected, CT scan is the primary tool which is used for detecting thoracolumbar fractures. It has been found to be 100% sensitive, 97% specific, and has an extremely high negative predictive value. The advantage of a CT scan is that it, additional to the anterior elements, it is the best modality for diagnosing injuries to the posterior elements, that is the pedicles, the laminae, the spinous processes. It helps to quantify the amount of spinal canal compromise because of retropulsion of bone. It helps us to study the morphology of injury so we can plan our pedicle screw fixation better. And it is also extremely sensitive in identifying posterior ligamentous complex injuries. The next assessment is an MRI scan. The MRI scan shows you the soft tissue extremely well. And therefore, if you want to diagnose disc disruption or disc herniation, injury to the ligamentous complex around the spine, presence of spinal cord compression, the direction, the cause of the compression, and the severity, and any intrinsic signal changes within the cord are all seen with an MRI. Every patient who has a neurologic deficit must have an MRI scan. In patients with suspected posterior ligamentous injuries, an MRI is extremely helpful and is the gold standard for diagnosing posterior ligamentous complex injuries. Finally, occasionally, very occasionally, one needs dynamic X-rays. If at the end of your X-ray, CT, MRI, you are still unsure whether this fracture is a stable or an unstable fracture, what one does is around 4 to 5 days after the injury, when the patient is a bit more comfortable as far as pain is concerned, sitting or standing X-rays are obtained. If when the patient's spine is loaded on sitting or standing, the patient experiences severe back or radicular leg pain, paresthesia, numbness, or weakness, then we diagnose this to be an unstable spine. Or if on loading the spine, the vertebra translates, the interspinous interval increases, there is facetal subluxation, or the kyphosis increases to more than 20 degrees, then what you thought initially as a stable injury may actually be an unstable injury and therefore may require surgical treatment. This essentially is the end of our emergency treatment. And now we come to decision making about the definitive treatment of the patient. The first thing when we think about definitive treatment, and that is the step one, is to identify what is the pattern of injury by identifying the primary injuring force. And here, the AO group has come up with a fantastic classification. Magrel and others studied 1,554 thoracolumbar fractures and came up with a very detailed classification. But as residents and even for clinicians, what is important and what helps you is just identifying whether this injury is A, which is a compression injury, B, a distraction injury, or C, a rotation injury. What is the difference between these three? Let me try and show it to you. What is a compression injury? Compression is an axial loading injury with the patient in a neutral position. When such an axial load occurs, we know that 80% of these compression loads are borne by the anterior column, which is consisting of the disc and the vertebral body. And therefore, the entire load is borne by the disc and the vertebral body. And therefore, what fails is either the disc, which ruptures and herniates, or the vertebral body gives up and it fractures. But the key to the type A injury is that this ligamentous complex of the back, which consists of the supraspinous ligament, the interspinous ligament, the facetal capsule, and the ligamentum flavum, is intact. So a type A injury is where the posterior ligamentous complex is intact, but it is the anterior column which has failed. A type B is a distraction injury. The patient's body is usually flexed or bent forward slightly, and there is a distraction force applied. When that happens, the injury travels from the back to the front, from posterior to anterior. And the first thing that is injured is the posterior ligamentous complex. So the tear is a tear of the supra and interspinous ligaments. There is often a tear of the facetal capsule and the ligamentum flavum. And these occurs in distraction or in opening up or in tension. If the injury stops there, there is no anterior column injury. But usually the injury travels further anteriorly, and there is a secondary injury to the anterior column which can travel through the disc, through the bone, or it can travel through and through from back to front in a through bone called as a chance fracture. Very rarely, especially in hyperosteotic spines of ankylosing spondylitis dish, a distraction force can be applied in extension of the spine. So spine goes into extension distraction, and here the anterior longitudinal ligament fails first, then the intervertebral disc, and then the vertebral column goes retrolisthesis. The third type of injury that the AO people described was a rotational injury. Now, most of you are orthopedic surgeons, and orthopedic surgeons understand rotational injuries in long bones, which cause spiral fractures. A similar injury can occur, rotational or translational injury within the vertebra, which results in disruption of the disc, the vertebra, as well as of the posterior elements, and is a highly unstable situation. So how do you identify each of these injuries? When I look at the X-rays, I first try to see, is this a type C, the rotational or translational injury? And how do you diagnose that? If in the coronal plane, the transverse processes are not, or spinous processes are not well aligned, the transverse processes are fractured close to the vertebral body, the ribs are fractured on one side but not on the other hand, there is an asymmetric compression of the vertebral body or a lateral translation of the vertebral body, then this is in fact a rotational injury. If it is not a rotational injury, then what can it be? It can be either compression or distraction. So how does one diagnose a distraction injury? A type P distraction injury can be looked for clinically by examining the back, and if there is posterior spinal tenderness, swelling, bruising, or a step or a gap between the spinous processes. On X-ray, as you can see on the X-ray on the left side, there could be an increase in the intraspinous distance of more than 2 millimeters compared to the adjacent level. There can be a horizontal fracture of the spinous processes, distraction of the facet joints, or a localized kyphosis more than 20 degrees are all features which help you to diagnose a distraction injury. If there is still doubt, an MRI can be used. As you can see on the image on the right side, the MRI is showing an increase in the signal intensity between two spinous processes, and there is a break in the continuity of the supraspinous ligament, indicating that the posterior ligamentous complex is insufficient. If, however, there is still doubt, then after 4 to 5 days, one can get a dynamic view, which is a standing X-ray, to confirm whether it is distraction or not. So if it is not rotation, if it is not distraction, then by exclusion, what is left is a type A compression injury where the posterior ligamentous complex is intact. So this is the crux of everything that you will learn about thoracolumbar fractures, and you must remember that there are only 3 types of spinal injuries: type A, type B, and type C. A type A is a compression injury where the majority of the load is borne by the vertebral bodies and the disc. The posterior ligamentous complex is intact. A type B injury is a distraction injury. Here, what fails first is the ligamentous complex at the back, and the injury then travels from posterior to anterior, and therefore the vertebral body fracture is the last part of this injury. And type C is a rotational injury where both the anterior column and the posterior column are disrupted, and it's a highly unstable injury. Your job when you look at the patient is first, is this a rotational injury? Look at the X-rays, CT scans, try to see any evidence of rotation. If there is no rotational injury, is there any evidence to suggest that this patient has a distraction injury? If there is no distraction, then by exclusion, this is a compression injury. The second step in the decision-making arcade is to decide whether to operate or to treat this patient non-operatively. And what are the factors to consider? There are 4 basic factors that we consider: improvement of neurologic deficit in patients who have deficits, In patients who have compromise of the canal because of bony retropulsion, should we clear the canal? And biomechanically, there are two indications for surgery: stabilization of an instability and correction of spinal deformity. So let us examine each of these indications. Neurologic deficit. About 20 to 36% of all patients with thoracolumbar fractures will present with some kind of neurologic deficit. Type C injuries have far more chances of developing a neurologic deficit than does type B compared to type A. A complete neurologic deficit does not improve. If at the end of spinal shock, the patient has a complete neurologic deficit, the chances that this patient will improve neurologically is almost close to zero. This is because this is a high energy injury which has resulted in irreversible neuronal death, and therefore complete neurologic deficit by itself is not an indication for surgery. A progressive neurologic, you've seen the patient in the emergency ward, patient has come and he's almost normal neurology. You see the patient after the imaging is over, examine him again, and you find that the neurology has dropped. This is a progressive deficit, and this is a well indicated indication for surgery. What is controversial, however, is a stable incomplete deficit. What do you mean by a stable incomplete deficit? Incomplete deficit is one patient who does not who still has some power, sensation, or reflexes below the level of the injury. And this is stable, this is not progressing. Should you operate these or not? If you look at the literature, there are no double-blinded randomized trials which suggest that surgery should be done in these patients. And therefore, no clear evidence that surgery actually will result in improvement in neurology. However, any surgeon who has operated on these patients will tell you that reduction in local tissue pressure by decompression aids in neurological recovery, and we have all seen this time and over again. And therefore, neurologically, there are two indications for surgery: a progressive deficit and a stable incomplete deficit where there is evidence of canal compromise. The second indication we consider is the clearance of canal compromise. What is canal compromise? When there is a burst fracture of the vertebra, bone from the posterior wall of the vertebra goes backwards into the spinal canal, causing compression of the nerves. In the old days, when only X-rays were available, this was not seen to be a major issue. But with the advent of CT scan in the 1980s and then subsequently MRI scan in the 1990s, people started seeing these retropulse fragments very clearly anatomically. And people started getting frightened that these could cause major deficits or they could result in late onset spinal stenosis. And therefore, people started operating for canal compromise. However, Scapinelli et al. Showed that the canal actually remodels on its own if left alone. And within 12 months, more than 50% of improvement in canal dimensions is seen. And therefore, Dixon concluded that canal compromise in the absence of neurologic deficit is not an indication for surgery. So canal compromise is only important when the patient has an associated neurologic deficit. If the patient does not have a neurologic deficit, even if the person has a 50% canal compromise, one can easily leave these patients alone. The third indication for surgery is correction of spinal deformity. This indication too is controversial because in our country, we have plenty of patients with tuberculous kyphosis with significant deformity who are living comfortably without any pain. However, in a paper by Gertzbain, it was shown that patients who at the end of fracture healing had more than 30 to 35 degrees of kyphosis ended up having a lot of chronic back pain. Mumford showed that if the patient was treated conservatively, whatever type of treatment was chosen, the kyphosis increased by an average of 8 degrees over a period of 1 year. And therefore, it stands to logic that if the initial kyphosis was more than 20 to 25 degrees, which would mean that if you treat it conservatively, at the end, the kyphosis was likely to be more than 30 degrees, which caused chronic back pain. And therefore, if the kyphosis more than 25 degrees, or if the anterior vertebral height loss was more than 50 degrees, then these are considered indication.
हेलो
हेलो
तो ऐसा सब बोला था, तो फिर मैं बोला ठीक है, क्योंकि आज से चालू हुआ क्या, फ्रॉम फर्स्ट?
कैन यू प्लीज प्रकाश प्लीज कीप क्वाइट.
No, I muted, sir. I think it was accidentally.
So initial kyphosis is more should be considered for indications for primary surgery. Stabilization of instability is the final indication. What exactly do you mean by instability? The loss of the ability of the spine under physiologic loading, which is normal loads you take during day in, day out, to maintain its pattern of displacement so that there is no neurologic deficit, no major deformity, and no incapacitating pain is what is called as instability. Today, instability is the primary indication for surgery because if the spine is unstable, patient can land up with progressive deficit, very severe back pain, progressive deformity, and therefore become bedridden. How do you define instability? How do you actually objectify instability? So Holdsworth in 1963 came up with this concept, which he called as the two-column concept of instability. He divided the spine into two columns, the anterior column, which was made up of ALL, disc, vertebral body, and the PLL. And there was a posterior column, which was made up of the pedicles, the spinous processes, the vertebrae, the laminae, the facet joints, as well as all the ligaments at the back. He said if the injury was only an anterior column injury, this is a compression injury and it is primarily stable because the posterior ligaments are intact. On the other hand, if the posterior column fails, then it usually fails in distraction. That means the ligaments are torn apart. Ligaments heal poorly, and therefore there is a potential for significant kyphotic deformity in the future, and therefore a posterior column injury is an unstable injury. So he emphasized that if there is a posterior column injury, it is an unstable injury. If posterior column injury is not there, it is a stable injury. Denis in 1983 challenged this concept, and he came up with the three-column concept of instability. He divided the spine into three columns: anterior column, which consisted of the ALL, the anterior two-thirds of the vertebral body, and the disc. There was a middle column which consisted of the posterior one-third of the disc and the vertebral body, along with the posterior longital ligament. And all the structures behind that formed the posterior column. According to him, the middle column was the crux to the essence of stability. Because the middle column, if it fractured, the posterior wall of the vertebra fractured, then it resulted in retropulsion of bone, which caused neurologic deficit. If the posterior wall was fractured, there was a collapse of the vertebra into kyphosis, and therefore it was the middle column which was resulting in all these problems. And therefore he said, if one column injury, any of the anterior or posterior column is injured, then it is stable. But if two columns, either the anterior middle or the posterior and middle, are injured, then this is an unstable injury. The AO classification and the most modern classifications like the TLIX classification are based on the two-column classification of Holdsworth of instability. The AO classification says that type C injuries are rotational injuries. The anterior column is ruptured, the posterior column is ruptured, the unstable in all directions. So this is a highly unstable injury. You must always operate on these type C injuries. A type D injury is a distraction injury. The posterior ligamentous complex is injured. The injury is unstable in flexion. There is a significant potential for kyphotic deformity, and ligaments heal poorly. And therefore, you must almost always operate on type B injuries. That leaves behind the last one, which is the compression type of type A injuries. This is controversial. A type A injury is essentially stable because the posterior ligamentous complex is intact, and therefore instability is not an indication for surgery, and therefore a type A injury requires surgery when there is associated significant deformity or neurologic deficit. So type A injuries sometimes operate. So if you were to summarize these indications for surgery, all type C and type B injuries you must operate. That leaves behind only trying to make sense out of type A injuries. So a type A injury you operate if there is a partial deficit or a progressive deficit, if the kyphosis is more than 20 to 25 degrees or the collapse is more than 50%. Clearance of canal compromise is not an indication for surgery. What is my protocol for non-operative treatment of these injuries? Non-operative treatment is limited to type A, which are stable injuries, and in patients who have no neurologic deficit and where they do not have a significant deformity, such as in this patient and with this kind of X-ray and CT picture. In these patients, what I do is I keep the patient in supine in bed for 4 to 5 days until the pain is a little lesser. Then we encourage the patient to get up and we take a standing AP and lateral X-ray. If on standing up, the patient does not get any significant radicular leg pain, paresthesia, weakness, and on X-ray you do not see any increase in vertebral collapse or kyphosis, then this is in fact what we thought was stable is still a stable injury and you can continue non-operative treatment. In these type of patients, I do not recommend bed rest. I do not use a belt. I start active back exercises for these patients. The third step is the surgical approach. Should you go anterior? Should you go posterior? Or should a combined approach be used? Well, the factors to consider in decision making are, does the patient have a neurologic deficit which requires a decompression? What is the status of the posterior long ligamentous complex? Is it disrupted? Does it require reconstruction? And how bad is the collapse or the comminution of the vertebral body? Will it be able to bear the loads of the body? Weight. So let us look at the first one, the need for decompression. We all know that a progressive neurologic deficit and a partial deficit with spinal canal compromise are indications for decompression. The methods for decompression are direct and indirect. Indirect is what is done posteriorly through a procedure called as ligamentotaxis, and a direct decompression can be done anteriorly by doing a vertebrectomy or posteriorly through a transpedicular approach. Ligamentotaxis is not unlike what is done in extremity fractures. In patients who have an intact posterior longitudinal ligament, if distraction is applied, the posterior ligamentous complex becomes, posterior longitudinal ligament becomes taut, and this then pushes the retropulse bone backwards into its original place. This procedure can be used in patients who have intact PLL within the first 48 to 72 hours after the injury, and those who have a moderate spinal canal compression, which is less than 50%. In patients where the spinal canal compromise is more than 65%, this procedure is not recommended for decompression. One must additionally remember that only fragments from the middle third of the posterior wall can be reduced. Fragments which are very large and will not be reduced by this procedure. In large fragments with severe spinal cord or conus injury, where canal compromise is more than 65%, where the injury is more than 72 hours, or the posterior longitudinal ligament is disrupted, a direct decompression is preferable. This in the good old days used to be done by laminectomy. It was later realized that laminectomy in fact destabilizes the spine further, and therefore the anterior approach became popular, where one did a corpectomy or a partial corpectomy, decompress the spinal cord from the front. But in the last 20 years or so, what has become popular is the posterolateral transpedicular approach, through which the neural structures are decompressed. Now, it has been clearly shown that the neurological and functional recovery rates are similar between the anterior and the posterolateral approaches for decompression. What about the status of the posterior longitudinal ligament or the posterior ligamentous complex? In an intact spine, the center of rotation of the spine lies in the posterior 1/3 of the disc. In a patient who has a type A compression fracture where the posterior ligamentous complex is injured, the center or instantaneous axis of rotation moves slightly forward and downward, but it is still within the vertebral body, and therefore potential for kyphotic instability is less. However, in a type B and C injury where the PLC is disrupted, the instantaneous axis of rotation moves anteriorly and inferiorly, so that the lever arm for the posterior ligamentous complex increases, the kyphosis therefore worsens, and there is huge amount of flexion instability. In all such patients where the posterior ligamentous complex is disrupted, it is vital to restore the tension band in order to prevent unlimited distraction of the posterior element. This can be done either through a posterior approach or an anterior approach. The advantage of the posterior approach is that it allows direct approach to the area of the tension band. It restores the tension band, it allows more rigid fixation, and it can easily be extended. And therefore, today, for all type B and type C injuries, it is universally accepted that when the posterior ligamentous complex is disrupted, a posterior approach is mandatory in order to instrument and reconstruct the tension band. The third thing to consider as far as approach is concerned is the severity of vertebral body collapse. All of us know that 80% of the loads are borne by the vertebral body disc complex. In a patient who has a vertebral body fracture which is badly comminuted and shattered, their entire load of the human body is borne by the implant which you have put in. The implant bears 100% of the load, and this implant is called as a load-bearing implant. And we know that eventually load-bearing implants fail from fatigue if not adequate anterior reconstruction is not done. And therefore, what is recommended is that in any patient who has a severe vertebral body collapse, one must reconstruct the vertebral body in one fashion or the other, so that the vertebral body can share the loads with the implants. This becomes a load-sharing implant and therefore is less likely to fail. This anterior column reconstruction can be done from the anterior approach, where one does a corpectomy and introduces a cage or strut graft, or one can do it from a posterior approach. How does one decide which patient requires to have anterior column reconstruction? Generally, it was thought that if the collapse is more than 40 to 50%, then this vertebral body requires a reconstruction. McCormack and Gaines provided what is called as the load sharing classification. Based on the on the sagittal and axial CT scan, they scored the fracture into points 1, 2, and 3. Also, based on the amount of kyphosis correction that was expected on lateral X-ray. Why is this important? When you correct the kyphosis of the vertebral body height is restored. And when the vertebral body height is restored, the compacted bone leaves behind a vacant area in the middle, which, if it is not filled up, will again collapse. And therefore, it is vital that if you do too much of correction, an anterior column reconstruction is necessary. What are your options for anterior column reconstruction? One can put bone graft from the back into the front through the pedicle using a funnel and pushing graft into the vertebral body. This is called as a transpedicular bone graft, which shores up the vertebral body. What is very commonly used these days is what is called as an index screw, or a screw which goes into the fractured vertebral body. This helps to strengthen the construct by increasing the pull-out strength and the stiffness. The third method of doing this is by doing a kyphoplasty using bioresorbable cement in these patients. Here, after the vertebral body height is restored, a vertebral biopsy needle is passed into the vertebral body which is fractured, and a balloon is inflated in order to elevate the end plate. The balloon is then removed and cement is injected so that the end plate does not fall back. What I like to do is that instead of distracting, which causes a void in the vertebral body, I compress, I shorten the vertebral column so that on table, the bone comes closer to, the end plates come closer to each other, and therefore the chances of failure are much lesser. The final method, of course, is what we discussed, that you can do a vertebrectomy and then reconstruct with either iliac crest strut grafts or cages, and this can be done through an anterior approach or from the back itself. Therefore, the posterior approach is today the most preferred approach for dealing with thoracolumbar fractures. Why? Because in patients with posterior ligamentous complex injuries such as type B and C, it helps us to restore the tension band. Through a transpedicular approach, we can posteriorly, we can do an excellent decompression, which has proven to help neurological and functional recovery. Through the posterior approach, we can do adequate anterior column reconstruction by a variety of different methods. And we can do a posterior fusion also. Additionally, the posterior approach is familiar to all spine surgeons. It offers more rigid stabilization than an anterior approach. It can be easily extended and cephalad and caudad, and the morbidity risk and complications of anterior approach are avoided. So has our anterior approach been given up altogether? The answer is no. A number of surgeons still prefer anterior approach for patients with severe anterior cord or conus compression. For patients with lower lumbar burst fractures where one does not want to, where the nerve roots do not allow us easy access to the anterior spine. For patients with segmental fractures where we want to limit the amount of levels instrumented and therefore we want to do an anterior fusion. And in old fractures where the bone has healed and therefore one has to actually do a corpectomy to decompress the canal. The next step in this treatment process is, if you are going posteriorly and fixing the spine using pedicle screws, how many levels should you fix? Should you go one level above the fracture and one below? Should you go two above and two below? And why is this important? When you do short instrumentation, it works on the tension band principle, which is essentially a load sharing principle. Anterior column reconstruction is extremely vital because otherwise the tension band will fail, the short instrument construct will fail. The advantage of the short instrumentation is that it restricts motion to a lesser degree. The amount of muscle dissection is less, reduced operative time, blood loss and infection. A longer instrumentation means that if you have to fix two levels above or below or anything more than that, this works on the bridge principle, where the bridge plate spans a weak area. But when you are spanning a weak area, you require more holes in the bone above and below. In these patients, often anterior column reconstruction is unnecessary. But because you are fixing more levels, there is more loss of motion. There is increased muscle dissection during surgery with increased blood loss and operative time. So when should you do a long posterior instrumentation? In all type C injuries, which have rotational injuries or translational injuries with fracture dislocations, one must there is a severe loss of ligamentous complex, muscle injury, and in all these patients, a long posterior instrumentation is preferred. In patients with more than 50% collapse of vertebra, usually one requires to do an anterior column reconstruction. But if the patient is not fit for an anterior column reconstruction, then one chooses to go a little bit more posteriorly, longer, so that it gives you that much more breathing time and allows the bone to heal before the implants would fail. Should you fuse or should you not fuse is the final debate in the management. When should you fuse? All type B and C injuries have posterior ligamentous complex injury. We know that the ligaments don't heal very well, and therefore if they can result in persistent instability, and therefore fusion must be done at the level of the ligament injury. Additionally, if there is a huge amount of disc disruption, fusion must be done at the level of the disc disruption. Fusion can be done either posteriorly. If you are not decompressed, you can do it between the spinous processes and laminae of adjacent vertebrae. You can do posterolaterally through an intertransverse fusion, or one can do a facet joint fusion. Rarely, if there is severe disc disruption, one can do an intervertebral disc interbody fusion. So to conclude this session, I would like to say that whenever you see a thoracolumbar fracture, the first step you have to remember is that based on your your knowledge of the type of injury and looking at the clinical and radiological aspects, identify the injuring force. There are only three types of injuries. Type A is a compression injury, type B is a distraction injury, and type C is a rotational injury. The next question you ask yourself is, should we operate or not to operate? We know that type C is unstable, so you must always operate. Type B is almost always very unstable, and therefore type B also almost always operate. Type A injuries are stable injuries, so instability is not an indication for surgery. Here, surgery in type A injuries is required for patients who have either a neurologic deficit or a significant deformity. Once you have decided that surgery is required, how do you decide on the approach? Today, the posterior approach is ubiquitously preferred by most spinal surgeons because it allows excellent decompression through the transpedicular route. It allows reconstruction of the posterior tension band in type B and C injuries. And even if anterior vertebral collapse is severe, one can reconstruct the anterior column in thoracolumbar injuries from the back itself. Instrumentation, should we do long or short? Long instrumentation is preferred in relatively osteoporotic bone and always in type C injuries or type B injuries where there are fracture dislocation. When should you fuse? Type B and C injuries where there is ligamentous damage, one must fuse at the level of the ligament injury. So remember this, type C are rotational or translational injuries. They are unstable because the posterior ligamentous complex is disrupted, so you must always operate. Decompression, instrumentation, decompression is posterolateral transpedicular, instrumentation is posterior, and anterior column reconstruction is necessary if collapse of the vertebral body is more than 50%. In these injuries, always instrument long and fusion is done at the level of the ligament injury. Here is an example. You can see the lateral translation of the vertebral body, a rotational injury, where we have done a posterior approach, long fixation, and then an anterior column reconstruction. A type B distraction injury, posterior ligamentous complex is torn. It is an unstable injury. Decompression may be required if there is evidence, if there is a neurologic deficit. If so, do it as a transpedicular approach. Instrumentation, posterior done through the same sitting, and anterior column reconstruction necessary if collapse more than 50%. Instrumentation, prefer short instrumentation because the ligament injury is localized to the level of the disruption. Short fusion limited to the level of the ligament injury. Rarely, there are type B injuries called as chance fractures. These fractures are bony injuries which are horizontal, occur through the posterior elements at the back and travel across the vertebral body in the front. If this patient does not have a neurologic deficit, you could choose to put this patient in an extension cast, and because it is bone, it will heal very fast and patient should do well. Here is an example of a distraction injury. You can see the opening up of the spinous processes at the back, where we have gone from the back and done a short posterior stabilization with an excellent result. The final type of injury, a type A compression injury. Here, it's a stable injury because the posterior ligamentous complex is intact, and therefore surgery is indicated only if the collapse is more than 50%, kyphosis more than 20 to 25 degrees, or patient has a significant neurologic deficit. Surgery can be done in these patients either through the front or from the back, depending on your choice and skills. But if you're going from the back, it is a transpedicular decompression. Posterior instrumentation can be short segment, and anterior column reconstruction is necessary if collapse is more than 50%. So here is an example of a patient who had a very severe partial neurologic deficit with a fracture at L2 and a very severe canal compromise, where an anterior approach was done, anterior partial vertebrectomy and reconstruction after decompressing the canal. So what are my take-home messages? The first message for residents is that whenever there is one fracture, always look for another one. The most commonly missed fracture is the second one. Injury to the posterior ligamentous complex is frequently missed, almost 25% of the patients. Look for a posterior ligamentous complex injury. Clinically, there may be tenderness, there may be step or gap palpable. On X-ray, you may find increase in the interspinous interval. There may be either distraction of the facet joints. There may be translation occasionally, though this could now fall into a type C injury if there is a translation. On MRI, you may find disruption of the supraspinous ligament or hyperintensity signal within the interspinous ligament. And if you're still doubtful, get dynamic X-rays and prove that this is not a stable injury. Whenever there is a posterior ligamentous failure, by modern definitions, it indicates instability. PLC injury with rotation is an AO type C fracture, which is unstable. PLC injury without rotation is an AO type B fracture, which is also unstable. And no PLC injury is a stable injury, that is AO type A fracture. Today, surgery is indicated for all patients with spinal instability, that is for type B and C injuries. And in type A injuries, you operate if there is an incomplete neurologic deficit, a progressive deficit, or a significant anterior column loss or kyphosis. In all type B and C injuries, posterior tension band must be restricted to reconstructed to provide stability. And the final message is the principal cause of instrumentation failure is an inadequately restored anterior column. And therefore, whenever you are choosing to instrument the spine, make sure that your anterior column is not terribly comminuted or unable to take the loads of the body. To conclude, the final message I would like to give is remember your A, B, and C, and you should be easily able to treat most thoracolumbar fractures. Thank you.